Hello, everybody. We are going to go ahead and get started. We will likely have more people join as the session begins. My name is Anna Lambertson. I'm the Executive Director of the Harry Cell Leukemia Foundation. For those of you who are new to the foundation, welcome. We're very happy that you're here. We hope that you will return and participate in other programs that we offer throughout the year. And for those of you who are back, having participated in a previous program, welcome back. We're really happy that you're joining our webinar session today. The Harry Cell Leukemia Foundation is a nonprofit organization established in the United States in the mid-1980s. Since then, we have grown to provide education, support, and research funding around the United States and the world. And so webinars such as the one today, we offer free to patients and families. People can join from anywhere in the United States or abroad. And we offer a variety of other support services that are, again, free to patients and families. We do encourage you to take a look at our website and register for other programs that may be coming up throughout the year. In addition to webinars such as the one today, we also offer a community roundtable series that's a peer-to-peer support series. It's online via Zoom. But through those meetings, we find that individuals with hairy cell leukemia and their families are able to connect with other patients, ask questions, and receive support. So we really encourage you to check out our program calendar and register for any of those community roundtables. We generally have at least one community roundtable happening every single month, so please take a look. Today's webinar is part of our clinical trials webinar series. It's a series that I'm particularly proud of and excited about because through this series, we provide an opportunity for you to connect with an individual who is conducting research right now in hairy cell leukemia, learn about their research, and ask questions directly from the individual conducting the research, which I think is a really unique and wonderful opportunity for everybody in our network. I will introduce our speaker in just a minute, but I do want to provide a little bit of housekeeping. So Dr. Park will provide a slide presentation. Once he's finished with his presentation, we will have Q&A. The opportunity to ask a question you'll be doing that in writing. So on your device, there should be an icon that says Q&A. You can type your question into that space. I will be monitoring that Q&A throughout Dr. Park's presentation. And once his presentation is done, I will start to read some of those questions to him, and he'll be able to respond. This entire session will last about 50 minutes. And we want to be respectful of Dr. Park's time, so we're really going to try to stick to that time frame, but we will try to get to as many questions as we can. Dr. Park is a hematologist and a researcher at Memorial Sloan Kettering Cancer Center in New York City. He treats patients who have both acute and chronic leukemias, including hairy cell leukemia. He also conducts research, and he has significant expertise in immunotherapy and a variety of other innovative approaches to treating leukemia. Dr. Park and Memorial Sloan Kettering are also a grantee of the Hairy Cell Leukemia Foundation. So we are very proud through donations from patients and families just like you. We are funding this clinical trial that Dr. Park is going to talk about today. So we are extremely proud of the ability, because of generous patients and families donating to this effort, we're able to provide support to this trial. We did launch this initiative in partnership with the Leukemia Lymphoma Society about 4 years ago. And it's been a really great way for us to fund not only clinical trials, but innovative research across the United States and at several locations around the world. So Dr. Park, thank you for being with us today. I am going to turn the time over to you, And we look forward to hearing more about your trial, more about your research. And then once you're done, we'll take some questions from participants.
Right. Well, thank you, Anna, so much for the kind introduction and also about the organization itself, too. I've been very fortunate to be part of Harrison Leukemia Foundation for many years, who have been great partnership and providing fantastic education and resources for our patients and supporting several kind of the research projects. So today I'll be talking about and highlighting kind of one particular clinical trial that we are currently running that's also supported by Harrison Leukemia Foundation, as Anna mentioned, in conjunction with the Leukemia Lymphoma Society. Throughout doing so, I'll provide some background, providing rationale of why we're doing such studies. Even though today's talk is focused on newly diagnosed, but the naturally leading up to it, I'll be talking about some of the therapies and recurrent relapse hairs leukemia patients, which is where it started first, and now we're moving this therapy to in the newly diagnosed setting. And hopefully I'll spend about first 20, 25 minutes or so. So we'll leave enough time to answer any questions you guys may have at the end. So as Anna mentioned before, so I'm from Sloan Kettering Memorial Sloan Kettering Cancer Center in New York City. I'm one of the leukemia physicians treating hairy cell leukemia at our center. So although you're more familiar with it, as you may also are dealing with it or your family members, I'll kind of set the ground, talk about what hairy cell leukemia is. As you can see the pictures on the right upper hand corner, the hairy cell leukemia gets actually its name because the cells, when you look under the microscope, they have this hairy-like the projections here that you can see, and hence the name hairy cell leukemia. It is a type of a chronic B-cell lymphoproliferative blood cancer. It just simply means that our bone marrow, these are bone marrow based disease. It starts to make these abnormal B cells, these hairy cells, and too much of those, and hence the name lymphoproliferative. And it's a type of a B cell, which is hairy cell belong to. So it is rare disease. It is epidemiologically, it is estimated to be about 600, 800 new cases per year in the United States. So, compared to, 300,000 new cases that we see of the breast cancers and so forth, these are obviously extremely rare disease. Although I have to say that we are seeing, the increasing incidence of those who are being, through the awareness of the kind of the foundation and being tested, and the pathologists are being more awareness as clinicians that we're seeing, we're finding some incidental finding of hairy cell leukemia who may not need any therapy, but we're making the diagnosis. The key clinical features and how the patients typically do present to the clinic about diagnosis is one is enlarged spleen. The second is the abnormal blood counts, which are probably the most common way of presenting. And it can come in with the many different clinical situations. One is anemia, which simply means low hemoglobin. The second one is thrombocytopenia, which means the low platelet cell count. And then the neutropenia, which means a low absolute neutrophil count, or low neutrophil count, which implicates a increased infectious risk. The third finding is bone marrow fibrosis, which may not be appreciated as much, but when we do a bone marrow biopsy, oftentimes hairy cell leukemia patients have a fibrotic marrow, and this is typically kind of found when we do with your bone marrow aspirate. You may actually be heard that we have a dry tap. We're not able to get the flow or the quote unquote good samples and so forth, and that's often because it has a fibrotic marrow, so we don't actually get a lot of fluid when we do the bone marrow aspirate. No significant clinical significance per se, but other than getting the kind of the bone marrow aspirate, you may hear about them, and it is one of the known features of the disease itself. The lastly, which is highly relevant, is the hairy cell leukemia carries this BRAF B600E mutation in more than 90%. It's almost always this mutation is present for classical hairy cell leukemia patients. The BRAF itself is not unique to hairy cell. That same mutation is present in many other cancers, and including many solid tumors, such as melanoma, and such as other blood cancers too. But what is unique in hairy cell is almost all hairy cell leukemia actually carry this mutation, which means it implies that the mutation itself is a critical component for hairy cell leukemia survival. So by and by targeting that specific mutation, that we might be able to get a deeper response, which we'll get to that, and then how we have developed the BRAF targeted approach. Before we get there, we'll talk a little bit about the clinical background of what is conventional. I put in a quotation mark. It was a traditional, conventional, or you may also consider to be as the standard hairs leukemia treatment. For newly diagnosed patients, for many, many years, over 20 years, the standard therapy has been either cladribine or pentostatin. This is a type of intravenous chemotherapy that we do have in the category of a purine analog, and that's the class of a chemotherapeutic agents. But again, either cladribine or pentostatin alone could result in about 60 to 80% of the time complete remission and 10 to 20% of the time partial remission. Complete remission refers to complete normalization of the blood counts and the reduction of the spleen to a normal size, plus the absence of morphologic absence of a hairy cell in bone marrow. Partial response means everything of the complete remission, the complete remission meaning the normal blood counts, normal spleen size, but when we do a bone marrow biopsy, that we actually still do see some hairy cell leukemia, so hence the partial remission. So if we don't do a bone marrow biopsy, we really can't say whether it's complete or partial. We just simply use the word clinical remission, which means the normalization of the blood count and then the reduction of the spleen size. So these numbers are fantastic results. So for those who have had other blood cancers or family members or friends with other blood cancers, these numbers are really fantastic result from the single agent in just a few weeks of a chemotherapy itself. However, we don't consider the cladribine or pentostatin alone to be a cure. About 30% of the patients will experience recurrent disease after receiving cladribine or pentostatin. And we believe they do have a recurrence of disease because by itself, while they are great restoring normal blood counts, but they never really get rid of the hairy cell leukemia completely from the bone marrow. So if we actually use a very sophisticated way of looking for or sensitive assays to look for hairy cell, almost always we will find them. And those are called measurable residual disease or MRD. So in the vast majority, in almost all cases, will be MRD positive if we use a cladribine or pentostatin alone, and those remaining cells in 30% of the time will eventually grow and lead to recurrence of dropping of the blood counts, enlargement of the spleen, again, very similar to the initial clinical presentation, and needing a second therapy. Now, in order to better address those, it's another approach is what about if we add rituximab, which is anti-CD20 targeted antibody. So it is a form of immunotherapy. It's an IV formulation. If you add a cladribine plus rituximab together, that does improve complete remission rate much higher and reduce the recurrence rate to about 5% or sometimes even less than that. So it does get into a deeper remission and therefore less chance of recurrence. And if we have time, we can talk about it, but it's a little bit beyond the scope of this clinical trial highlight. But the question is that the cladribine alone versus cladribine plus rituximab for newly diagnosed patients. Overall survival is the same, meaning that you will live just as long whether you get cladribine and cladribine plus rituximab, but your chance of a recurrence or needing a second or subsequent line of therapy will be lower if we get the cladribine plus rituximab the first time. Now, these therapies are great, and you may argue that we might have solved all the problems here. So leukemia with this chemotherapy and then rituximab combination, they were getting rid of them in the vast majority, do not even have a disease recurrence. So what is the problem? So these chemotherapy, as you may imagine, are associated with the immune suppressions. Chemotherapy is not a targeted therapy, so they are impacting normal cells, and essentially all hematopoietic cells will be impacted. So normal white blood cells, normal lymphocytes, normal red cells, and platelet cells will be affected. So what that means is that once you get the chemo, your blood count may start here, and they will dip down and hit nadir, or lowest blood counts within a few weeks of the chemotherapy, and they will eventually recover. But during that low time, what neutropenic time or thrombocytopenic time, the infectious risk is high. So the estimated rate of a neutropenic fever, meaning having fever or infection while your blood count is low, the neutropenia, is about 40% of the time. And that does mean hospitalizations, whether it's a few days, 2 or 3 days of hospitalizations, or 7 to 10 days. it's about 40% of the time that it is likely to happen. And obviously that does depend on what is the blood count when you start with. So there's a caveat to that, but that is estimated in the clinical trial reports. So that is the biggest side effects associated with the chemotherapy. If depending on what the number that you're starting with, because there is a dipping down or lowering of the normal blood counts, you may require more blood and platelet transfusions after the chemotherapy. This makes it harder for those patients who actually present with a very low blood counts and have concomitant or concurrent infections, and they need to be treated. And that does present kind of the conundrum or the kind of the problem as to giving chemotherapy when they're already sick to begin with, and we're making them feel worse in order to make them feel better in the long term. But during the short term, there will be a more increased risk of complications. And then lastly, the chemotherapy itself can cause second cancers, although those are rare events, but it can happen with any chemotherapy, but certainly with a cladribine or pentostatin. So, we saw the limitation of the cladribine first, and then also, as I mentioned before, about 30% of the time with the cladribine alone, the hairy cell leukemia can happen again. And when it happens again, they can get the chemotherapy again, and most of the patients will respond. But there are subset of the patients who get second or third time with the cladribine or pentostatin, and they stop responding, or they don't respond as long, and they only get 1 year and then of a remission, and then the hairy cell leukemia comes back. So we wanted to develop a therapy that what can we use in those patients who are either looking to avoid more chemotherapy or patients who are refractory or no longer responding to chemotherapy. And because we knew the BRAF mutations were present more than 90% of the time, in which we figured that it must be important if it's happening so often in hairy cell leukemia, it has to be an important mutation for the hairy cell leukemia to survive. So Enrico Chiasi and Bruno Follini from Italy actually made the first discovery that BRAF mutation was present in hairy cell leukemia in 2011 in publication. And shortly thereafter, many other centers, actually including ours, are looking for validating is that also the case in other centers around the country. And then the 54 cases that were looked at, 100% of the time the BRAF was present. And this table just summarizes that in subsequent publications of close to 500 patients that we validated and confirmed the presence of this mutation, the BRAF mutation, and with hairy cell leukemia. And what was also unique is that when the hairy cell leukemia recurs after the initial therapy, BRAF mutation continues to present. So, which is an important factor for when we're designing a therapy for recurrent or relapse disease, because the mutation may happen at the beginning, but they may disappear. But these are consistent or persistent mutation in hairy cell leukemia. So that does present a very good rationale for targeting this mutation in hairy cell leukemia. And then with some of the data that we also did at MSK is that we actually looked at the hairy cell leukemia initiating cells. So kind of the parent cells, and the BRAF mutation was also present. So which made us think that if we ever get closer to the hope of a curing hairy cell leukemia, we need to get that the first cell that initiated hairy cell leukemia, and if that cell contains the BRAF mutation, by targeting the mutation, that we might be able to hopefully get one step closer to cure. So with that, and luckily, there's already a medications that was approved for patients with a melanoma, and I told you the BRAF mutation is also present in other cancers, and it's also present in melanoma, and they have already developed BRAF inhibitor or targeted medication called vemurafenib for melanoma. It's already FDA approved. So we actually wanted to use that medications, could it work well in hairy cell leukemia? So we conducted a clinical trial both in Italy and MSK. It was a multi-center US study, so with several investigators giving vemurafenib, this oral the BRAF inhibitor alone for patients with relapse disease. The eligible patients or included patients for this clinical study are all relapsed or recurrent disease patients. Either they never responded to cladribine, which is rare, or they responded, but they had a recurrent disease, but they need to have more than 2 relapses, meaning they had to have another cladribine the second time, and that didn't work, or it only lasted a very short time, and for the third time, and they needed a therapy, and they could get on the study. This, again, is a recurrent or refractory hairy cell leukemia patients. And in order to participate in this study, and that's true for most of other hairs of leukemia studies, you need to have some evidence of a clinical significant disease, which means lower, the absolute neutrophil count, low hemoglobin, and then the low platelet counts, one of those. And the vemurafenib alone, and when we were initially designing the study, we also wasn't quite sure how long is the therapy should be given. In melanoma, because it studied a metastatic disease, the vemurafenib was given indefinitely until the drug stops working. So that could be a few months for some patients, that could be a few years for the other patients. But we didn't want to give the drug for too long, so we actually designed the study to give the medications for 3 months first. We did a bone marrow biopsy, and depending on their response, we could extend the drug duration for up to 6 months. So max of 6 months, minimum 3 months was the drug duration. We used the same dose that we used for melanoma, which was 960 milligrams twice daily. And then we just simply adopted that same dose of medication that we use in melanoma for hairs and leukemia patients. We treat 24 in US and then another 25 patients in Italy. So the combined is about 45 patients, the 50 patients together. And they have a similar result. And this is only the US data. But out of the 24, it actually responded 100% of the time. So all patients who received the pill alone instead of the repeated course of the clozapine or pentostatin responded. So when we look at the response, about 42% of the patients were complete response, and the other, the 58 or 60% were partial response. So everybody had a normalization of the blood counts, but when we did the bone marrow biopsy, about 60% of the time, we're still able to find for hairy cell leukemia. And those 60, out of those 60%, some of those patients had a recurrent disease, which is what this the survival curve is to show, meaning that initially, even though everybody responded, subset of those patients had a recurrent or relapse disease when they received the vemurafenib alone, kind of by itself. The second point I want to highlight is that the drug worked effectively and incredibly well. And because it was a relatively less toxic medications, we're able to use a drug for older patients or sicker patients. So median age, about half the patients were older than 62. And then the oldest patient that was treated on this trial was 80-year-old. So again, and because the mechanism of action side effects are very different than chemotherapy, that we are able to use the medications even for older patients as well. So the drug did have its own side effects, which we knew going in because the drug already, again, was FDA approved. So there's already existing experience with melanoma patients. Most common side effects are rash, joint pains are the two most common side effects I usually discuss with the patients, and then the ones we observed in this clinical trial. And the third and the fourth is hair thinning and sunburns, and photosensitivity could be quite significant too. So these grade 1 and 2 and grade 3 are really, it's a medical term that we use to indicate the severity of these side effects. And then obviously lower the grade, the less likely. So the grade 1 and 2, the rash and joint pains are typically ones you will notice that that's easily managed either with a Tylenol or Motrin, or you may not even need any medications or such pain medications to function. Grade 3 and higher are the ones a little bit more significant, meaning that you may need more than those medications, such as steroid or creams and other things to mitigate them. So even though the good number of the patients experience rash and joint pains, the most of which were low grade, and these are transient reversible side effect that happens within the first 2 or 3 weeks of starting therapy, and they do disappear. And the remaining 3 to 6 months of the therapy while you're on the medications, that you're able to stay on the medication to complete the therapy. So it's more of an inconvenience factor than anything else with the side effects. So the one thing that I told you that it worked very well almost always, but the patient never got rid of the hairs of leukemia completely from the bone marrow, and subset of the patients because of that had a recurrent disease even after vemurafenib. So the next question that we asked, as the investigator asked, is that what about if we add rituximab? Can we actually get a deeper or better response and reduce the chance of recurrence after using vemurafenib plus rituximab? with a very similar idea, because we already done this with a cladribine plus rituximab. So chemo plus rituximab, I told you at the very beginning that when you added the rituximab, which is CD20 targeted immunotherapy, that we're able to get a better response and deeper response. So we were taking similar rational approach, now adding into vemurafenib. And this is a completely chemotherapy-free regimen. And this is the data that Enrico Giassi from the Italy also published in 2021. And again, this is recurrent refractory patients who have failed or have already treated with a chemotherapy such as cladribine and pentostatin. In this study, they used the same dose of vemurafenib, 960 milligrams twice daily for 8 weeks, so 2 months. And then the rituximab here was given every 2 weeks for 8 doses with a total duration of a therapy of 18 weeks. With that, they had a great response. About 87% of the patients had a complete response. And what was different than the prior vemurafenib alone or monotherapy was that 90% of the response were MRD negative, which means that when we did the bone marrow biopsy, 27 out of 30 treated patients were not able to find any hairy cell leukemia. So that means that these patients are less likely to relapse because we wiped out the disease more completely. So that was encouraging, even though it's a relatively shorter follow-up. These are MRD-free survival, means that those patients who got MRD negative, really nobody has been relapsing, at least for the duration of the follow-up they had, which is about 30 months of a follow-up. So this was highly encouraging that when you add a rituximab, you get a deeper response, better response, reduce the chance of recurrence. So the next question then we asked that, can we actually, it works so well in recurrent disease, and can we take it to newly diagnosed patients? So instead of the chemotherapy-based regimen, can we actually use the same approach instead of a chemotherapy? Not after failing chemo, but what about instead of the chemotherapy? So hypothesis that we actually that is that even the chemotherapy work, and when we designed the study was a little bit, it was considered to be a bold step because, and I told you at the very beginning, most of our patients do very well, fortunately, with the chemotherapy-based regimen, but it has its own side effects. Not everybody is able to get it. If you're older or sicker or has an infection or a very low blood count, those patients, it usually is not as safe to give a chemotherapy. So for at least for those subset, and for those other patients who are simply looking to alternative treatments, non-chemotherapy options, we wanted to develop those therapy for them in the frontline setting, not after failing chemotherapy. And then the second is that, I told you the BRAF mutation is happening in early hairy cell initiating cells. So we wanted to see whether we can actually cure hairy cell leukemia. It's considered to be incurable at this moment as a chronic disease, but can we actually cure this treatment, the disease with a better therapy by getting rid of or targeting BRAF specifically very early on? So in order to do that, we wanted to use the BRAF inhibitor vemurafenib that has been tried multiple times in different clinical trials in hairy cell leukemia. And instead of rituximab, we actually swapped that with what's called obinutuzumab. It's a very same class of medications, but it's more potent. So it's a little bit stronger. It works better than rituximab. So we wanted to, in the frontline setting, that we wanted to give the best-in-class medications to hopefully get the best response with a deeper remission with the goal of less relapse and eventually a cure. So this study was also supported by the Hairy Cell Leukemia Foundation with vemurafenib plus obinutuzumab in now patients previously untreated. So this is the first time that we ever studied this combination in the world, actually looking at chemotherapy-free regimen for newly diagnosed hairy cell leukemia patients. The duration that we have chosen with the same dose of vemurafenib at 960 milligrams twice daily for 4 months continuously. We added obinutuzumab from month 2, so it started a month after, so for 3 months duration, and total of 5 doses of obinutuzumab infusion. 3 centers participated in the U.S. for this study, MSK, Dana-Farber, and Yale were 3 centers. Again, median age was 54, meaning half the patients were younger than 54, half the patients were older than 54. So youngest patient you can see is a 28-year-old, and I think avoiding chemotherapy makes even more sense for younger patients, in my opinion, because they do live longer and then they like to avoid any consequences, long-term consequences of the chemotherapy, but also certainly makes sense for older patients, and oldest patients we treated on this study was 82-year-old. So with this combination, that we had about 90% response rate at 27 out of 30 patients. The other 33 patients who actually dropped out of the study early, within the first month or so, is the patients who did get those side effects I mentioned before, rash and joint pains, and did not want to continue. But those patients who actually continued the therapy to 27 and completed them, all patients, 100% of those patients responded. And I told you about this MRD negativity, meaning when we do the bone marrow biopsy, what is the chance of that we don't see any hairy cell leukemia? That was happening in 96%. So this graph on the right is all showing this kind of the dramatic decrease is for hairy cell leukemia percentages in the bone marrow, pre-treatment and after treatment, that all patients' hairy cell leukemia disappeared. And these are staining for hairy cell leukemia, that all was gone. And looking for this BRAF mutation, at the beginning, there's a variable presence of BRAF mutation, and all disappeared after. So this is, again, just kind of another indicator of highlighting the complete and then the rapid eradication of the hairy cell leukemia with this the chemotherapy-free combination approach. And because it's chemotherapy-free and doesn't have the lowering of the blood counts at the beginning, because it doesn't impact the normal red and platelet and normal neutrophils, we're able to deliver the cells in outpatient in all patients except two who actually did start the therapy with concomitant infection, which chemotherapy would have been hard, but we wanted to test the hypothesis that we can safely administer this treatment in patients who actually had a fever and infections and other things. So with those patients, we did treat them, but in the hospital, and then they have completed the therapy and also responded as well safely. I just wanted to highlight the speed of the blood count recovery. I told you with the chemotherapy, you start here, and then there's always a dipping down or lowering down of the normal blood counts before they recover. Because this is chemotherapy-free regimen, that if you look at the platelet counts, which is most exemplary, the blood counts, there's no kind of dipping down. So from the very beginning of a starting therapy, and this red dotted mark here is first month, just 4 weeks, that you actually can start from less than 100 and recover very fast within 4 weeks, normal, without kind of the dipping low. So I think that just to highlight the speed of a response. And platelet is always the first blood count to recover. The second is a neutrophil, and even the neutrophil you can actually see is a more steady increase rather than there's no dipping down and going up. So because of that, we reduce the chance of having the febrile episode while your blood count is low. The lastly, then I told you I told you that everybody, that almost everybody who finished the therapy responded, and how many of those patients have recurred, and it's 0 so far. So no patients had a relapse disease so far, and the longest patient that we have treated is 7 years out. So these are very encouraging. The result, obviously, we would need a longer follow-up because you might have heard the hairy cell leukemia patients, the recurrence can happen many years later, even 10 years later. So while the 7 years is one may consider quite long for any other blood cancers, for hairy cell leukemia, that we do want a little bit more time to see that this is validated and is true beyond the 7 years, and certainly beyond 10 years and 15 years. We're going to continue to follow up these patients, but it is very encouraging nonetheless that no one has relapsed after their initial response so far in the newly diagnosed setting. So obviously, we're very excited about this data. It does has its own side effects, and there are some lessons that we have learned from this too. And it's the same side effects that we have seen in the relapse refractory setting. And the most common was the rash, arthralgia, which is the joint pain, and pruritus means just itching of the skin, which is actually pretty minor. But the rash and joint pains, I have to say, are the most common side effects, and that was one of the reasons that three patients that who discontinued the study did not want to continue the study. So these are still transient, reversible. They do go away once you stop the medications, or with Tylenol, Motrin, the pain is manageable. In some cases, we do use low dose prednisone, like 10 to 20 milligram, which is low dose for about 4 days or up to 7 days, and that's enough to eradicate these symptoms. But nonetheless, these are side effects that we do tend to manage. In contrast, the febrile neutropenia did happen, but in only 7% of the patients, as opposed to 40% of the time, which is estimated with a chemotherapy-based approach, which is dramatically lower. The last lesson that we have learned, and when patients do get the rash and joint pains, one of the things we do, other than kind of managing the symptoms, is a lowering of the dose of imurafenib. And this was the big question in the field, that we simply, when we designed the initial vemurafenib study, we simply took the dose that was useful for melanoma patients, which is 960 milligram twice daily, and just translate and took the dose to hairy cell leukemia patients. But we have learned that hairy cell leukemia and melanoma, it doesn't work as well. And it's a completely different disease. But the hairy cell leukemia is very sensitive to vemurafenib. So the question was raised that, do we even need this 960 milligram? Can we get away with a lower dose? So in separate other studies in Germany and other countries, they actually looked at doses as low as a 240 milligram twice daily, which is one pill twice a day. 960 is a four pill twice a day. So with with as low as 240 milligram, it actually worked just as well. So we in the side effects wise, that the one way to manage was a 400 milligram twice daily, and without going too deep into the data, we actually studied extensively in this study. The half the dose was as good, and actually almost everybody ended up in the half the dose for better management of the side effects. And so in the future, this is a dose that I'm using off clinical trial for the better tolerability, same efficacy, and this is a dose that we're using in our future studies, half the dose, in a hope that we actually get even better in the toxicity, the profiles. So I'm going to lead to my last slide, just highlighting the clinical trial that we are running currently, which is a phase 2. Now this is the same regimen, vemurafenib, obinutuzumab, same schedules. Only difference here is a dose of the vemurafenib. The difference here is a randomized study. So half the patients will get this chemotherapy-free regimen. The other half will get what's considered to be the standard, which is cladribine and rituximab, that's given weekly times 8. So we're now comparing side by side to see which one is safer and better. This is a multi-center study that is currently open and enrolling. We have treated a few patients at MSK. It will open also at Ohio State and Dana-Farber eventually in short sometime this year. So we're looking to expand the sites and those as well. And this again for newly diagnosed patients. So our main hypothesis here that we already know that both therapy works very well, but they never been compared side by side. So what's happening in the real world right now is that you can certainly get cladribine with rituximab as a standard therapy. You might be able to get vemurafenib, obinutuzumab based on our prior data in the newly diagnosed setting, but the NCCN, our Cancer Society guideline, has a restriction. It's only for older patients or patients who have a concurrent infection. So if you do not meet those criteria, insurance may not pay for that, even though that's not how our study was designed, but that's the reality that insurance payers are only providing for those two indications. So we wanted to actually compare definitively against the chemotherapy for appropriate patients. Can we actually expand the indication and then use the therapy for more patients if we believe it is appropriate? So our main hypothesis here is that obinutuzumab, the chemotherapy-free combination, will be just as effective as the cladribine rituximab, but safer with less side effects, especially infections, hospitalizations. The rate of blood and platelet transfusions are the key side effect markers, which impact the quality of life in the setting, the time off from work and in the hospital. Sometimes we have to administer cladribine in the hospital as well too. So we're trying to reduce those complications, inconvenience factors by using the chemotherapy regimen. And again, with the goal and the primary purpose of the study is that we want to establish this chemotherapy-free regimen as appropriate first-line therapy option for all patients, not just old patients, or not just with the concurrent infections. So it will be easier eventually to administer or to use this regimen for kind of wider group of patients. In the randomized study in the medical field is the gold standard, is the best way to convince the payers and the clinicians and then the patient's community oncologists who may actually see these patients more often to kind of have a more wider buy-in when you actually compare directly against chemotherapy. Effectiveness, I believe fully that they will be just as good for both based on kind of the single arm studies that we have conducted, but it's really kind of focusing the safety and other factors. And there are many other scientific questions that we'll be asking as a part of the study, and that's what the funding is also providing for. So lastly, I just wanted to thank you for your support. And please do spread the word that if you kind of belong to this category, have an interest about this, and other patients you might be speaking to, and then consider participating in the trial. The quicker we finish the study, the quicker that we can actually get this combination kind of to more appropriate the patients. So again, thanks for your attention. So I'll hand it back to Anna, and then we'll go over some questions.
Dr. Park, thank you so much. Really appreciate it. We're going to jump right into questions. There have been a variety of questions that have been coming through the Q&A. So just right off the bat, if someone wants to consider joining this trial, do they contact your team? And I believe we have, so on our website, through our patient support page, we do have a clinical trials section. You can go there and read all about current clinical trials that are recruiting patients. And I believe your contact information is listed there. So if you are interested in talking to Dr. Park and his team about your eligibility for this trial, you can contact them through that page. And they'll be able to discuss it with you. So what about individuals who are living outside of the United States? Are they eligible for this trial?
I mean, they're technically eligible. Well, it's difficult. It depends on the medical insurance coverage in the U.S. as well too. So we're trying to make it available to other centers, including Canada actually as well, which is not too far away, but different medical system. So even the drug itself is provided by the clinical trial. Your other medical costs will be covered by the insurance. So if your medical care is not covered in the U.S. regularly, it will be hard. But if you're one of other individuals who may have a kind of medical coverage, then you can. Then it will be easier. Otherwise, it will be hard. And you can only get these medications as in this clinical trial, one of the 3 centers participating, unfortunately. But that's the whole point that eventually we want to be available for many wider, but we have to get through these steps first.
Absolutely. Thank you. So I do want to jump into a few questions that came up about the drugs themselves, because we understand that this is a non-chemotherapy approach. So there were a few questions about the side effects that you shared in some of your slides. One of them is secondary cancer. So particularly with vemurafenib, what short or long-term risk for other cancers are you seeing with vemurafenib?
Very good question too. So, the vemurafenib duration is actually fairly short. It's only 4 months, and in other studies only 2 months. So, the secondary cancer risk is we haven't seen any kind of on this long term. So I'm not worried about those. But the ones that we have seen and it could happen is the squamous cell, either skin cancers, which is one particular type is a squamous cell carcinoma. We haven't seen any de novo, meaning if you've never had a squamous cell carcinoma, we haven't seen a patient it developed on study. But if you did have it before, you can actually have a regrowth, and it's scientifically related factors. And the same thing is true for kind of warts, those viral warts that you can actually grow, or the skin text can actually grow on it, and they amazingly regress once you stop the medications. So we know this can happen. These are short-term consequences and side effects. But having said that, because of this, we do highly recommend on clinical trial that every patient do get examined by dermatologists at the very beginning and at the end and throughout to better monitor. We did that in our prior studies, and that's how we know that it didn't happen in the de novo new cases, the ones previously. So if it were to happen, you manage it just as like you would do just resection and warts and skin text. We just leave them alone because they actually do go away once you stop the medications after kind of 4 months being on the drugs. So these are definitely manageable, but we have not seen any, luckily so far, any long term, not only here but in Italian studies as well.
Thank you. Another question about side effects. You did provide a list of some side effects, including rash, that you say do tend to go away after treatment ends. What about alopecia? Is that also reversible once the treatment concludes?
Yes. So all side effects, I know that there was a big table and which is available on the paper itself and go through them all. But all side effects is listed there as a transient reversible, including the hair loss. So I have seen some hair thinning in some patients. It's never hair loss completely, but hair thinning can happen. That's noticeable to the patients and sometimes to me as well too. And then including the eyebrow hair thinning, but they do grow back and they do go away. But kind of once you stop the medications. And then it's good in that sense the drug duration is relatively short.
Thank you. I believe during one of your slides, you mentioned the BRAF uh, V600 positivity goes away after the vemurafenib treatment. Can you touch on that? Um, and does that also occur with cladribine and rituximab, or is that just with the BRAF inhibitor?
Sure. So that's a good point. So the BRAF mutation is a hallmark feature, and it is present because it's hairy cell leukemia. So if you don't have any hairy cell leukemia, then you won't have any BRAF mutation. So they do go away even with the chemotherapy because simply by the fact that hairy cell leukemia disappears. Having said that, that's kind of the one mechanism. So chemotherapy, it doesn't go specifically to BRAF, but it does kill hairy cells non-specifically. But by killing the hairy cell, BRAF goes away. The reason I mentioned those kind of the mark about the BRAF mutation analysis, a digital PCR is a one specific way to measure BRAF. We have a very sensitive way. So simplest way of measuring response is you look under microscope, do I see any of those hairy cell projections like cells or not? Yes or no. If I do, partial response or no. But as you can imagine, those are very crude and not as sensitive. And you can actually have a various different ways. BRAF measurement is one of the most sensitive way that we can take a look at them. So by proving the fact that we're not seeing any BRAF, we're simply indicating that we're not seeing any trace of a hairy cell leukemia with the sensitivity that we're getting into, which is typically kind of 1 out of 100,000 and sometimes 1 out of 1,000,000, meaning out of million normal cells, 100,000 cells, we're not seeing a single hairy cell leukemia. So that's the kind of the speaking to the sensitivity of the assay, kind of the meaning deeper response.
Thank you. I appreciate that explanation. Um, Another question that came up is, you discuss the rationale for using obinutuzumab instead of the obinutuzumab with the vemurafenib, which we know in Italy, Dr. Enrico
No.
Chiacci is doing a parallel um, study using the vemurafenib and the rituximab on the second arm, because as you pointed out, this is a randomized study.
Yes.
So if someone joins your study, they will be randomly assigned to either the vemurafenib or the cladribine arm.
Correct.
For the cladribine and rituximab arm, is that concurrent? It looks like it's concurrent. So the rituximab, just for everybody listening,
Yes.
rituximab given essentially at the same time as the cladribine. Can you discuss that?
Sure.
Why you're going with the concurrent as opposed to the delayed rituximab for the
Sure.
second?
Sure. All very good question, and you fully and then the obinutuzumab versus rituximab question also has been highly discussed kind of in hairy cell leukemia the meetings as well. So we have our own rationale for using obinutuzumab in the frontline setting, but it certainly is not wrong to use rituximab, and we simply don't know. We never compare vemurafenib plus obinutuzumab against vemurafenib plus rituximab, so we don't know one is better than the other. But we have studied obin combination, so that's the reason that we have taken to the randomized study. So that's kind of one rationale. The second, cladribine rituximab, you're absolutely right. There is usually kind of largely many different ways of giving cladribine plus rituximab when we use combination. The combination that I've shown you here, what we have adopted, is the one that Dr. Kreitman or NCI has developed, which is a concurrent cladribine plus rituximab. So given together. The other common regimen, the second common regimen is what MD Anderson has used before, Dr. Robandi and others. So you start with the cladribine first, and the rituximab comes at week 4 with week 5. Still same number of rituximab, 8 weekly dosing, but you start later. Kreitman also studied the delayed rituximab, so they only do it several months later after cladribine if there's any evidence of the cladribine coming back. We do know that that's too late to use the rituximab, but within 4 weeks is a probably good, okay time to use rituximab combination. We have chosen the cladribine concurrent rituximab combination because it is the most common way that's given I found in the community by referring the base. And there's a randomized clinical trial actually that supported the use of the cladribine plus rituximab concurrent in this approach that came through the Kreitman's NCI group use this regimen. So that's the reason that we have chosen that combo schedule for this arm.
Thank you, Dr. Park. Are you okay on time? Do you have a few more minutes to take
Yes, I do. I could definitely spend 10 more minutes if you do need them.
Why don't we, if you're willing, why don't we take a few more questions over the
Yes,
next few minutes. I appreciate your time.
no problem.
We do have an individual who has been treated using the vemurafenib and obinutuzumab regimen for someone whose B cells continue to improve. When do you expect for patients? Maybe clarify that a little bit for everybody listening, what that means, the B cell recovery, and what you can expect from the vemurafenib, plus one of these monoclonal antibodies.
Sure. So, the obinutuzumab and rituximab, and I told you they're CD20 antibodies. So CD20 is a marker that's expressed on hairy cell, but it's also expressed in normal B cells. And in the normal B cells are part of our lymphocytes and part of the immune system, and these are the cells that fight infections. It's different than neutrophils; they do different function of the immune system. But these are the cells, simply speaking, making antibodies important for virus infections, response to vaccines, for example. So same thing can happen after rituximab and obinutuzumab because both arms is using these medications. The B cells will be suppressed, just like the hairy cells suppressed, B cells will be suppressed. Not permanently, they will recover. Typical time frame, it is variable. We typically do think about the rituximab and obinutuzumab even when we use them alone with the combination with other chemotherapy at least 3 months, typically about 6 months after the last dose of rituximab or obinutuzumab to recover the B cells. Not normal, but they have some recovery enough that that's the time that we recommend about vaccinations and then so forth because you're going to respond to them. Prior to that, you can still get them, but you may not respond just as well. And that's sometimes a conversation we get into, usually cladribine versus cladribine plus rituximab. Who should get it, when should get it, what are the side effects, and why wouldn't everybody want the rituximab, and why would somebody don't want to get it? It depends on some seasonal factors, their history of infections, because of this kind of normal B cell count, even though it's transient, it is several months down. So anywhere between 3 to 6 months is time that we begin to see the recovery, but full recovery can take additional 3 to 6 months after that. Typically, they have no significant clinical consequences, meaning they don't have to be hospitalized. I don't consider it to be an increased risk of infections. People do travel. When they ask me a question, can I go on a cruise or can I go on a plane? And I say, yes, you can do that public transportation. Obviously, if it's a flu season, I just say, wear your mask, wear hand hygienes and things like that. But that's the time frame that we can think. But it is variable because of person to person.
Thank you. And again, because I think what is so exciting about this trial is that you'll be comparing the non-chemotherapy to the standard chemotherapy regimen. So for someone comparatively who has done cladribine rituximab, does their recovery, I guess, trajectory look similar to those in general who are doing the vemurafenib and the obinutuzumab?
Correct. And that's the exact reason that we're doing this randomized study, as you mentioned eloquently, because we have our single arm study data, we have a cladribine data, but never in a one single study. So we'll be looking at B cell recovery, which in my opinion may not be that much different, but we'll take a look at them. But I kind of glanced over it, but the T cells are other component of immune system. So we usually think of a neutrophils, B cells, and T cells. And B and T are the part of the lymphocytes. Cladribine is a quite T cell suppressive, which is a known factor. And that's the reason cladribine is also used for T cell lymphoma or T cell leukemia because it impacts the T cells. So with a cladribine based approach, your normal T cells will be low, and that's the reason sometimes we have to think about specific infections against it when you think about T cell suppression with a cladribine or pentostatin for that matter. And so they could be low, but vemurafenib doesn't touch the T cells. So we already know the T cell recovery is already better with the vemurafenib obinutuzumab, but we'll be looking at many different immune recovery in a single study, neutrophils, B cells, and T cells to see whether there are what are the consequences of those. And I do think there's one of the benefit, even though they are both B cells suppressive, at least the T cells and neutrophils will be less so with a chemotherapy-free regimen. It's not wrong to get chemotherapy by any means. I'm not saying that you shouldn't, but these are the things that will be weighing side by side.
Thank you. And again, I do want to, stress that it's because of previous research that you did and published using the vemurafenib and the obinutuzumab. And again, previous research already published using cladribine and rituximab and the great results from those two regimens that we're now, or that you're now at a place where you can really compare them in this randomized trial. And that's so this isn't a study that came out of nowhere. This is building on years of research there at MSK, in Italy, and other institutions that have already proven the value. So we do have some questions about MRD,
Yep.
which for those of you listening, that's minimal residual disease, MRD. Just a lot of questions about, are you seeing the same MRD negativity using these two regimens? And if there is a difference, what difference are you seeing? And again, just not just within this clinical trial, but I mean in general, what are you seeing between these two regimens?
Yes. Outside of the clinical trial that, most of you guys may not even get the bone marrow biopsy after getting this regimen because your blood count will almost always will be normal. But when I discuss with my patients what is the value of doing so, it's looking for MRD. And for those patients who are looking to kind of a little better look for outlook for the kind of long-term outcome, what is my chance of relapse? I want to know how completely it worked. I think these are the value of an MRD. We know for them obinutuzumab in the clinical trials because we had to and we did the bone marrow biopsy and those are MRD negative, and I told you this before, kind of all patients receive. The rate of MRD negativity I would expect to be very similar between cladribine plus rituximab or vemurafenib plus obinutuzumab, which is going to be very high. Over 90% of the time, they will become MRD negative, meaning kind of with the current technology of assays, we're not going to be able to detect the hairs of leukemia. So the rate of MRD negativity may not be that different. Now, for those who actually have MRD positivity, I also don't want you to worry too much or to be disappear because it doesn't guarantee that you're going to relapse or it's not destined to relapse either. You're more likely compared to MRD negativity, but that disease can take a really long time to develop into recurrence, and there are patients who never really get there. There's actually great data that even you can have a 20 to 30% hairy cells still remaining, but they are just remaining and not impacting your blood counts too much, and you may not need a second line of a therapy. But in a clinical trial, it is important because it's one way for us to gauge what is more effective or not in a short term. But the rate, I think, will be very similar between the two when you add a rituximab. It's higher than when we use a cladribine alone, though. So that we do know that when we use a chemotherapy alone without the rituximab or obinutuzumab, that MRD negativity rate is much lower.
Thank you. Earlier in your presentation, you did talk about the value of the non-chemotherapy regimen, particularly for what you classified as younger patients, because multiple treatments with the chemotherapy can result in stem cell issues. How do you define younger patient versus older patient, just for our audience to understand?
I know, and there's really no good the divider. The median age of hairy cell leukemia, it is younger. It's about 45 to 50 patients. So, if you consider other chronic disease like CLL and others, those are 65. So these are 20 years younger. So hairy cell leukemia is already happening in younger patients. What is young? I mean, I think I consider 60 to 65 is also still very young. Sometimes it's it's very, very arbitrary kind of the numbers. 20 and 30 years, so certainly very young. But anywhere who's 60, 65 younger, I think it will be kind of younger category. To be honest, in 65 to 75, there's a group is the other comorbidities they have, their life expectancy because of those, and their quality of life is all kind of comes into the factor making a decisions about those. And I think the field is in oncology in general is trying to get away with a more targeted approach, the targeted approach doesn't mean no side effects. Yes, it does have its own side effects too. We may trade one problem for another, but as long as the trade is fair and significant, I think it does that makes sense. I think for me is the infections or the transfusions or hospitalizations or hopefully the secondary malignancy or the toxic the hematopoietic cells in the bone marrow. If we can avoid them, it will be good. So we're trying to get stepwise and very scientifically rigorous way. And as Anna mentioned, testing one after another, kind of the series is now have finally kind of led up to this. Hopefully it will take a couple of years to not only complete and then read out with a study, but we're getting very close. So we're very excited about this approach too.
Thank you, Dr. Park. I do want to we are at the end of our time. I do want to stress how important it is. We would not today in 2025 have the ability to test these treatments cladribine wouldn't even exist had patients not at some point, in their kind of journey with hairy cell leukemia, decided to join a clinical trial. And so this clinical trial can't happen without patients joining. And Dr. Park and his team will do everything they can to educate you about the process. There are clear criteria for you to be aware of, as Dr. Park has said. Having the BRAF V600 positivity, you cannot have previously been treated for your hairy cell leukemia. So this is truly for patients who have not previously been treated. I'm just reiterating that because a few of those questions have popped up in the Q&A. We encourage everybody to, if you have not previously been treated for hairy cell leukemia, and if you have the BRAF V600E mutation, to consider joining this clinical trial. Please, on our website, on our patient support page, you can access information about our clinical trials. We can also, if you're interested, feel free to reach out to us and we can connect you to Dr. Park's team to discuss kind of more specifically your eligibility. Dr. Park, thank you so much. We're so grateful to you. With all the kind of leukemias in the world to treat, we're so grateful to you for devoting time in your lab and time in your clinic to treating this particularly rare disease. We're so grateful to you. Thank you for taking the time today.
No, I just wanted to reiterate one thing. I know
Sorry.
to take a step forward. I just really echo kind of and it's your kind of what you just said. It's a patient participation is always the key, and the funding itself is fantastic from the Hairy Cell Leukemia Foundation. But at the end of the day, these are all of you, the patients who actually participate in the study, is moving this field forward, and without them, without you guys, this would not have happened. I still think about my very first patient who participated in bemobinituzumab study, who was the world's first patient to receive this first combination. And when I knew it was going to work well, but kind of together to going in there, and when there's a good chemotherapy options, but kind of going in, and that patient is kind of more than 7 years out that I still continue to see in my clinic, but still incredibly grateful to open that door for the patient. Because once you see that it works in first patient, it's a lot easier to talk to subsequent patients to get this. But it takes a lot on them, and I don't take it lightly by any means. I'm still very thankful, and for all the patients who participated. And that's really the only way that we can to do this best way, and the only way to do it. So I just wanted to echo kind of what you said, and kind of it's a really incredible teamwork, and I feel so grateful to be part of this community.
Thank you, Dr. Park. And thank you to everybody who joined today, who listened and asked questions. We appreciate you. Please reach out if you need more information. Thank you, Dr. Park. Enjoy the rest of your day.
Thank you, guys. Thank you, Anna.
Bye. Thank you,
Bye.
everybody.